So thank you for attending my grandma. It's IgA Nephropathy. I'm from fellow graduate. I have nothing to explain. Objective is like understanding the pathophysiology of IgA Nephropathy, understanding why proteinuria is the surrogate endpoint for the IgA Nephropathy, important to new FDA framework for the drug to the IgA Nephropathy. And the last one, exploring the treatment option. IgA Nephropathy was first found by the French pathologist Jean Baget. Before 1968, IgA nephropathy was thought to be because of the IgG. But this French pathologist found that it's IgA is played a major role in IgA nephropathy. So this is the global prevalence. Traditionally, this is very high prevalence in East Asia and Asia, like which is high in Japan, Australia, Japan, China, Singapore. But due to the migration, the United States is catching up to like now 27.3% of people that have IgA nephropathy right now. This is IgA. IgA immunoglobulin have stayed in the Martin mark, which means like two immunoglobulin in chain with the J joint in the middle. And there's a in the middle, and then there's a secretory protein to secrete into the mucosa. So there's a subtype of IgA1 and IgA2. I think it's really interesting because IgA1 and IgA2, the difference is in the hinge region. IgA1 have the longer hinge region, more flexible. Since it's more flexible, it's easy to catch more and be more antigen, and then it stayed in the circulation. Major about 8% of the IgA1 are in the circulation. The hinge region is longer. Since the hinge region is longer, there's 16 more amino acids in the hinge region of IgA1 compared to IgA2. It's more susceptible to protease in IgA1, and then in this longer hinge region have 6 O-glycan location for the galactose binding site. So this is how it look like. The reason I'm telling you is that the binding of galactose in the IgA1 is very important in pathogenesis of the IgA nephropathy. If you have in patient with IgA nephropathy, they have deficient in galactose binding in the area called the GalNAc, which is called glutamine galactose, which is called GalNAc, right here. This GalNAc without galactose, this open end is very antigenic, and it's going to create the autoantibody for the IgA, and it's going to create the binding site for the immunoglobulin IgG. So that's the very beginning of the pathogenesis. We have 4-hit mechanism in IgA nephropathy. Why we have 4-hit mechanism in IgA nephropathy? Because 1 hit is not enough. When you have hit 1, which means that you have antigen coming to expose to T cell, T cell going to stimulate B cell and then secrete the plasma. The plasma is going to secrete or make the galactose deficient IgA, which serves as the source of the antigen, serves as the antigen for the self-binding autoantibody to the IgA or IgG, going to bind to this, the galactose deficient IgA1. It's going to form the immune complex, and it's going to deposit in the mesangial area of our glomerulus, and it's going to trigger mesangial proliferation, mesangial expansion, and that's called hit 4. So I was like, when I read that, like, okay, this is literally type 3 hypersensitivity. But what's the big deal? Like, why do we have to explain this 4 hit? Because 1 hit is not enough. Because like in terms of that, this is important to understanding like why do we have to do diagnosis, do biopsy in IgA nephropathy? Because like you can have the glycogen deficient IgA in the circulation, you can detect the glycogen deficient IgA by ELISA, by Latin dependent by way, non-dependent by way, you can find this glycogen deficient IgA, but you don't necessarily have to have the disease. You can also find this immune complex. You can check it from the urine the immune complex in the urine, but that doesn't mean that the patient going to have this IgA nephropathy. And then this immune complex can be degraded by the liver cell in liver by kappa cell. So you can find this immune complex in the circulation, but it's not necessarily mean this patient going to have IgA nephropathy. So the gold standard is still the biopsy for the IgA nephropathy because of that reason. So clinical feature, it can be microscopic hematuria or gross hematuria. Proteinuria can be nephrotic, subnephrotic, AKI. Majority of time, the AKI is because of the glomerular bleeding that lead into the ATN. And usually it should recover in 2 weeks. Or sometimes you can see the crescent GN. The Z progression is very, very rare. The majority of people have asymptomatic hematuria, asymptomatic proteinuria, and a very slow progressive kidney disease. Maybe about 20 to 40% of the patients will end up getting ESRD or transplant in 20 years. But very uncommon is rapidly progressive kidney disease and severe nephrotic syndrome. Because of that, until recently, we don't have a lot of medication for IgA nephropathy. We can use the ACE or R, we can use the ACE or R, we can use the steroid, that's all. There's no other medication because the disease progression is very slow to test the effect of the medication. It takes longer trial. You have to spend, pharmaceutical companies have to spend a lot of money on that, so they don't want to do that. But the FDA and FDA and KHI and ASN decide to do something about that. I will talk about that later. The associated condition in the IgA nephropathy. So we have to make sure that this IgA nephropathy is idiopathic. It can be associated with the associated condition like cirrhosis of the liver. Obviously, if immune complex can be metabolized by these liver, if you have cirrhosis of the liver, you have increased chance of immune complex deposits in the kidney, which can trigger the complement pathway. So if you have cirrhosis of the liver, you have any chance of IgA nephropathy. In celiac disease, in lymphoid tissue of the GI tract can trigger producing of glycogen deficient IgA that can also associated with the IgA nephropathy. HIV can also trigger the IgA nephropathy, and then NGS, of course, if you have the plasma cell dyscrasia, you can produce the IgA heavy chain deposits in the kidney or CGMID of the IgA. So you have to rule out these associated conditions first before you consider this is the idiopathic IgA nephropathy. So the renal biopsy play a major role in the treatment and the diagnosis of the IgA. So what are we going to see on renal biopsy? In the light microscopy, you're going to see a mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, Htun, and then crescent. So based on the degree of the finding, you can rate as M0, M1, E0, E1, F0, S1, T0, 1, 2, and C0, C1, 2. So this is going to guide you to think about the prognosis of this patient. Number one, it may also guide you how you're going to treat this patient. For example, if you have like F2, and then you don't have any of M0, E0, S0, and then C4, you C1. So if you have F2, then are you going to give steroid or not? Because that's the current state. You might not see any acute inflammation. So it might not respond to any of the treatment that you do. So this is if you're staying on the IF, you want to see an IgA dominant or IgA co-dominant staining that you're going to see. and you're going to see C3 and kappa lambda staying, but you're not going to see C1q almost all the time because the Fc portion of the IgA cannot fix C1q. So you have to understand that in IgA nephropathy, classical complement pathway is not part of this because C1q is the beginning of the classical pathway, and then theoretically the IgA cannot fix the C1q, but it can fix the C3, and so we think it alternative complement pathway and leptin complement pathway might play a role in IgA nephropathy. And you're going to see electron dense deposit in the mesangia, in the subendothelium, and on the IF. So this is based on the mass C score. There's also you can do also classification. So this is what I found in this article. So you can kind of like guess like what is the 5-year dialysis ESRD prognosis. If you have like 0, you probably have 0 chance to become ESRD in 5 years. But I would if you have this 0 E0 sum for MEST. So you can have M1, E1, you can have both M1 and E1 is stay risk 2. But as when you involve S, you don't need to necessarily have any other thing. You can have risk 2. With S with something else become 3, and the S when you involve T become, if T alone is going to be risk class 3, if T with something else is going to be risk class 4. So if you have risk class 1, 5-year ESRD risk is 0, risk class 2 is 4.4, risk class 3 is 12.8, and then risk class 4 is 13.16. So this is just like best side you're thinking about, like if you see the biopsy report, you might think of the heart first ablation prognosis. Or you can also do this. You can do international IgA prediction to put all these variables that you got when you do the biopsy of the patient, and they can spit out the percentage of 50% decline eGFR or progression to ESRD in 5 years. So you can spit out the same thing. So I try this and then like, okay, this is pretty good. So this is what KHI and the ESN and FDA try to find, like what should we do about this IgA nephropathy, because like nobody making any new drug for the medication. They try to do the meta-analysis, like, so what should be the surrogate marker? Surrogate markers are if you improve something now, disease progression, the disease outcome might change in future. So they try to find different surrogate marker, and then they found that the proteinuria is the only one that could be measurable, and then they can use as a surrogate marker in the future. They did 11 randomized control trial, which was intervention was done by corticosteroid immunosuppression and RAS blockage. They see about 50% reduction in proteinuria can reduce the hazard ratio to 0.4. And then the proportion of the treatment, because of this proteinuria, the treatment outcome can change about 10% in each and every other treatment, and but steroid is changed about 30%. And then in trial level analysis is also show the effect of proteinuria compared with the control group. The hazard ratio about 0.37. So the proteinuria, treating of proteinuria is good for the outcome of the IgA nephropathy. But how long do you want to keep this proteinuria under control? As much as we can, but like sometimes we don't know. So this shows the effect of the proteinuria and the treatment outcome. And then they did another trial, like how long do you want to keep this proteinuria under control, and then what's the effect? So they did they reviewed 7 international cohort meta-analysis. By improved IgA, the time varying exposure of proteinuria less equal or more than 25% reduction from the baseline, or less than 1 gram per day. And then the primary outcome was ESRD or 50% drop in eGFR. So if you can, from that analysis, if you can keep the proteinuria under control, every treatment you reduce the hazard ratio of 0.9, which is up to 4 years. But after 4 years, the outcome is not going to change. So because from that, this is the new framework that's for the FDA for now. So every new study that you're gonna read from now for IgA, all the pharmaceutical company will come to you with this. Okay, our medication reduce the proteinuria about this percentage in 9 months, and then by that means they can get approval from the FDA, and then we can look at the GFR change in 2 years time. So by this means, if you create a new medication, if you can reduce the proteinuria from the baseline about the significant percentage, you can get the accelerated approval from the FDA for the treatment of IgA. That's why we have so many trials right now, try to focus on the decreased proteinuria. So should we treat, let's talk about the treatment. Like if we have a patient with IgA dominant glomerulonephritis, we have to rule out all the associated factors after the compound. This is the idiopathic IgAN, look at the Massey score and think about do we have to treat or not. And then if we're going to treat, we're going to decide to treat, because before we treat, we have to consider about these things. I got this from the 2024 IgA Nephropathy clinical guide, which is still not published yet. I mean, there's a reason why it's not published yet. I will talk about that later. And treatment goal for the IgA nephropathy, if you want to treat a patient, our goal is to reduce the GFR less than 1 ml per minute per year for the rest of the patient life. And then proteinuria excretion, it traditionally used to be less than 1 gram, but with the new guidelines, it's less than 0.5 gram in 24 hours, or less than preferably less than 0.3 gram. So when you're going to look at the patient, what are the risks of progression of the what are the high risks of progression? If you have the proteinuria of more than 1 gram, if you have a persistent microscopic hematuria in 2 different occasions, either you can do by distic or microscopy if more than 10 RBC in 2 separate tests. Progressive kidney decline, the GFR decline every year more than 3 in IgN. The Massey score show you have a M1, E1, C1, which are the indicator of there's active disease progression is going on, and then S1 with the podocyte hypertrophy. If you see these more than 3 or more of this, you see the patient has the high risk of progression. So this is what KDIGO proposed. Like if you have the IgA patient, you have to treat both conservative and then disease modifying. So they said that, okay, after we understanding the IgA pathogenesis, we want to decrease the amount of galactodeficient IgA production, which can be done by using Nefecon, which is target release budesonide. The immune complex deposits in the glomerular until the glomerular don't be inflamed. You can reduce this inflammation by using systemic corticosteroid or using complement system inhibitor. And then you can also conservative management by doing blood pressure control, reduce glomerular hyperfiltration of the proteinuria, and then reduce the cardiovascular risk by giving RAS inhibitor, HAD2 inhibitor, and sparsentan. So I have to add this complement system inhibitor and atrasentan on the KDIGO guideline because these medications were approved by FDA in November and this year April. And so that's why this KDIGO guideline is not published yet, but it's already a little bit outdated. And then if you have a geographic practice, like if you have Chinese patient who have the MMF, you can use MMF hydroxychloroquine, and then in Japanese people, they did one trial for the tonsillectomy, which is working for only Japanese patients. So let's talk about the Capello. So I think the name really smart. The target to be so okay, Capello. So this is the medication, targeted release budesonide. You take it orally. It targets the lymphoid tissue of the ileum. So in ileum, so this is the same thing. So you're going to see an gene coming in the you're going to present the CD4, then you're going to trigger the D cell, B cell, B cell going to produce plasma cell, and the plasma cell going to do the IgA. So by giving PR pledges, it's going to damp down this system, and then you're going to produce less galactose-deficient IgA. So we are expecting that help with the IgA patients. So let's look at it. So target release budesonide, this is the 9 months. So they are going to look at the protein, decrease in protein urea at 9 months. So which is minus 0.6 compared to 0.09. So they look at GFR at 0.7 ml per minute compared to 4.04, which is like very significant. So by that means, you can get approval by the FDA. So they look at the 2 years, because this medication is already approved fully by FDA, so they have 2-year trial, 2-year result. So in 2 years, the eGFR decline is minus 2.4 compared to minus 7.5. But in this trial, you have to understand that like the eGFR is more than 35 and 90. So you have, if you have CKD4, I mean, if you have CKD5 or 4, you cannot use these medications. But they are not tested before.
Did they ever, what, is there any paper on their mass score or anything, like did they mention it? Because, or did they just go strictly based on proteinuria and GFR?
They just go strictly based on proteinuria and GFR.
So no mass score.
No. So if you're going to talk about IgA, we have to talk about testing. So testing trial was done to compare between oral-methyprednisone and placebo. So it's a double-blind RCT, about 503 patients and followed by 4.2 years. So the inclusion criteria are 18-year-old or eGFR more than 20. And then they started treatment with the oral methylprednisolone 0.6 to 0.8 milligram with a maximum dose of 48 milligram and wing for 8 milligram per day per month. So after they did the initial, after they started the trial about when they reached about 263 patients, they noticed there's a serious side effect, including 2 patient deaths because of the infection. So they stopped the trial. But they reviewed the data. The preliminary analysis showed there's a significant favoring of the lower event rate of kidney failure, death and decline of GFR in 40% in steroid group. So they said, okay, let's restart the trial with the lower dose. So the reduced dose was reduced into half, 0.4 milligram per kg with a max dose of 42 milligram per day, and weaning for 4 milligram per day per month with the antibiotic coverage for the PKB. The primary outcome is the primary composite outcome, because that's a traditional trial. It was done a long time ago. So the primary composite outcome for 40% decline in eGFR, kidney failure, dialysis, transplant, or that they don't care about that proteinuria at the time. So the result, the patient, about 74%, 28.8, about 74 participants, 28.8% of the methylprednisolone group, compared with the 43.1% in placebo group, reached the primary outcome. So like it's significantly improved the patient renal outcome with the hazard ratio of 0.53. But the report is a combined report of both high dose and reduced dose. They look at the subgroup, and then the full dose have hazard ratio of 0.58 and reduced dose have hazard ratio of 0.27. But P for heterogeneity is 0.11, so which is not significant. So you can use either reduced dose or high dose, you're still going to have a good effect on the renal outcome if you do the continuous steroid. That's in trial. So then we have to talk about the stop IgA. This is the trial. It was done to see after you give the maximum supportive care, if you superimpose the patient with the immunosuppression, it is going to improve the renal outcome or not. So About total of 337 patients were running trial, running phase, which means that you treat the patient with maximum rest blockage. All these lifestyle criteria, control the blood pressure, low salt diet, regular exercise, do everything. And then re-evaluate after 6 months, and then look at the proteinuria. If the proteinuria is less than 6.7, they are excluded from the trial. If the proteinuria is say above 0.75 gram per day to 3.5 gram per day, if the eGFR is more than 30, they were included in the trial for running phase for 36 months, which is 3 years. So the immunosuppression, they divide it into two groups again. If you have a good eGFR of more than 60, they're going to treat with the oral IV and oral corticosteroid. If you have the eGFR between 30 to 60, they're going to give oral cyclophosphamide for 3 months, then azathioprine or the oral corticosteroid. The primary outcome is in this trial is there's two primary outcomes. Number one is the full clinical recovery, which means that proteinuria is less than 0.2 gram per gram, which did not write on this slide is that another full recovery criteria for this trial is proteinuria less than 0.2 gram per gram and or eGFR decline less than 5 ml per minute in 3-year trial. And then next criteria is decrease in GFR of more than 15 in 3 years. So if you look at this, the treatment group have proteinuria achieve about 5% of the patient. 5% patient achieve proteinuria less than so somebody can only achieve 5%, and then the treatment group achieves 17%. So you have the proteinuria recovery, but when they compare about the eGFR decline less than 5, there's no difference. And then eGFR decrease more than 15, there's no difference. So what my interpretation when I read this is like, okay, if you give the patient with the maximized rest blockage, supportive care, and you superimpose the immunosuppression on that patient, you're going to increase risk of infection. But the benefit is you're going to decrease the proteinuria in some patients, but you are not going to change the renal outcome.
But now you started all this by saying proteinuria is now an accepted surrogate for
Yes,
long-term.
that is the old trial. So I will get
So
it.
did they sort of take a look at the people who had a reduction in proteinuria? Because it's only 14 out of 82,
Yeah.
so who knows what it goes. But if you look at those people who reduced their proteinuria, what was their GFR change?
Yeah, I did not look at it. But the conclusion for the STOP IgA trials, like immunosuppressive therapy, might not have extra effect on the renal outcome. So like, okay, this is contradict to the testing. Like, why? So the comparison between testing and STOP IgA, so like when you look at the patient demographic in testing, people are younger with the similar GFR, blood pressure is controlled. Proteinuria is like significantly higher in testing trial. Most of them are in Chinese, and then if you look at the mass score, like M1, S1, but if you look at the STOP IgM, like M0, S, all them except S1s there, the impact on kidney outcome, you look at both, and then if you look at if you use the IgM thing, the risk of progression to eGFR in STOP IgM is only 15%. But in testing trial is 38%. So in testing trial, people are sicker compared to STOP IgA. And the real eGFR decline, the prediction is in testing trial, people are like about 5 ml per year. But in STOP IgA, the risk of prediction or eGFR decline is only 1.5. So like testing trial, people are sicker. So maybe that in people with higher chance to fail the kidney, like that worse prognosis in IgM patient might benefit in with the corticosteroid immunosuppression. But if you have relatively better, if you have a better, if you say have the very mild disease form, the immunosuppression might not add additional benefit over supportive care. That's what I understand. I might be wrong.
None of them did it based on the chronicity versus not. Like none of these trials are dissecting based on this because they all have apparently the mass score. They just are not using it for the criteria. So are there secondary analysis which essentially show that some of these work at one higher grade of disease and two where there is not much chronicity? Is that how they are interpreted? Like, was there ever an analysis like that?
That may be problematic because we know the MES score wasn't sort of looked at prognosis, which could be sort of underlying scar and other things, which is so to call it now to use it as pathogenesis, it's the only thing we have. But we do have to be careful to start thinking about this as in the pathogenesis of the disease and worse. But I'm surprised they don't use it more often, or there's haven't been a retrospective.
I think the part of the reason is that most of these studies, you can be entering in this study with biopsies from up to 10 years ago. You know, so the MES score, you know, and it's not mandated to enroll to get rebiopsied. So what does the MES score mean? You know, now I will say that for the testing, the modified testing, the second, you know, after the one that everybody, you know, there were people died and all that, with the modified testing study, if you look at the median time from entry from biopsy, it was only 5 months. So that was probably the shortest time frame between biopsy and entry on average for the, you know, for this cohort of patients. But what was interesting is that when you look at the weeds, whether you have E1 or E0, M1 or M0, it made no difference, you know, in terms of who responded and who didn't respond. So I guess what I'm trying to say is that overall, I have been a bit disappointed with regards to the correlation between the MES score and responsiveness to any of these study drugs.
I guess what so I think that's a very good sort of dissection, right? So my point where I am confused is that because for a lifelong pathology, and I'm so sorry, but for a lifelong pathology that is going on, the treatment decision in an empiric clinic visit is based on, we are currently, at least based on the trials, is proteinuria. And that's pretty much the inclusion criteria for most of them, with some preservation of GFR, a various version of it. And the concern here is that, like, there is nothing that dissects which part of acuity is responsive to your treatment. But there is a quote unquote non-responsive component of acuity. So the question that I have is that, do I just treat everybody at a random, and does the 6 months start when I see the patient, and all of those questions? And if there was some guide as with like that, hey, if you don't have significant M or E or S, you can back off or something like that. And I don't know whether, if any one of them is present, it's okay to treat. But if none of them are there, it's just T, or like if there is a tubular IFTA. At what point, like, what's the real way to decide this other than just proteinuria, which is random? I don't know the answer to that.
I think that, you know, before you start dissecting, you have to find something that works. So now that we have multiple things that are making a difference on the disease, I think the next step is to figure out who to treat, who is best for each one of these specific treatments, and maybe MES isn't the best thing to get at that the true pathogenesis of what's driving the disease. Maybe circulating, you know, underglycosylated IgA for and others, you sort of going down the mechanism would be better. But I think at least we have it now, something to start.
It's something people are responding to.
So, this is one of the new kids coming into the town. So, Sparsentan, which was recently approved by FDA. This is the compound have two effect. One is on endothelin receptor, and then another one. One compound have two effect on the when it's on endothelin receptor, one is on angiotensin 2 receptor. So they did a trial as because of new FDA guidelines, they show the proteinuria reduction of about 49.8, almost 50% in treatment group, and about 50% in the regular hyperstatin group. So, okay, this medication have good effect on the proteinuria reduction. How about the GFR in 2 years slope? So they showed two GFR slope. So they say that you should not count between from week 1 to week 6 because of all the hemodynamic change. But you should usually look at the eGFR slope starting from the 6th week to 110, with the name as the chronic eGFR slope. If you look at this eGFR slope, you have the eGFR decline of 2.7 compared to 3.8, with the difference of 1.1 GFR ml per minute difference, with the p-value of 0.037. Which is statistically significant. But if you look at the 2-year total eGFR slope, there's a 2.9 versus 3.9 difference 1, but p-value is 0.058. So it's not significant. But they use the fast chronic eGFR slope and then got the full approval.
So I think, I mean, just to put a perspective on this, because once you start putting these many numbers on a slide, it's very difficult to interpret, right? So I think if you are going to believe that that first one was important, you by almost extension will believe the second one is important. And if you're not going to believe the first one is important, then by extension you won't believe. So I think because at this level, your p-value just means that whether it is a little bit lower sample size or slightly marginally lower effect. So it's very difficult to just say not significant and significant.
I just don't want to. I don't want to create any enemy. The next one is Applause trial. It's the iptacopan. It is a factor B inhibitor. What is factor B? Factor B is part of the C3 convertase of the alternative complement pathway. There's two C3 convertase in leptin pathway, and then classical. There's one C3 convertase, which you usually call 2A4B C3 convertase, now 2B4B. Now in alternative complement pathway, the C3 convertase is 3BBB. So C3B bind with the BB factor B becomes C3 convertase. So when you block the C3 factor B, you're not going to find the C3 convertase on the alternative pathway, so you cannot trigger the alternative pathway. But that was the idea. So with this iptacopan, the selection criteria is also eGFR more than 30%. And the iptacopan have the significant reduction of proteinuria compared to placebo is about 38.3 with the confidence interval of 0.26 to 0.46, p-value of 0.01. So by that means we got the accelerated approval from the FDA, and we don't know the 2-year eGFR slope yet. Next one is itrasentan IgA nephropathy. Itrasentan IgA nephropathy. Itrasentan is also an endothelin receptor inhibitor. So this trial, the GFR criteria, I look at all the GFR criteria, everybody tested all the patients with eGFR more than 30%. This is also have a good benefit on the proteinuria reduction, about 36% compared to placebo. This is also got the approval from the FDA. Recently, we don't have the 2-year GFR slope yet. So this main trial was only done in China. It's only done in China. Is the primary outcome is the composite renal outcome, which is death, ESRD, or doubling of kidney. They don't talk about the proteinuria. So in the treatment group, only 7.1% reached the primary composite outcome. In standard care is 21.2%. It is confidence interval 0.09 to 0.63. And the EGFR progression on CKD progression is 8.2% in treatment group, and then 27.1% in the standard care. But it does not reproduce similar outcome when they did in Europe. So if you have Chinese patient, if you ran out of idea what to grade the IgG, you can probably think about the MMF. So hydroxychloroquine did this same study in the China. So I look at two trials, which is GAO 2017 and Leo 2019, because it's at the higher general score of 3 and 1. The higher this, the better general score. So this trial, this only look for 24 weeks. It's in one trial, and this one look for 6 months. And they say that there's a decrease in proteinuria compared to control group. But there's no difference in EGFR when you look at this. So you might also consider if you want to treat the hydroxychloroquine, if you have a Chinese patient, you can try.
Oh,
And then
I'll tell you this, that hydroxychloroquine is quite common in Asia for proliferative GN, for which there is no treatment. So China has it. In India, it's a standard of practice. So most people with either IgA or idiopathic MPGN, until at least the newer agents came up, were treated with chronic hydroxychloroquine therapy. And so these are supportive things, but there is a whole section, about 2 billion people practicing it.
Okay. Yeah. So our golden child, the SGLT2 inhibitor. So they did the DAPA trial, they picked CKD, DAPA CKD, but they never initially think about the IgA. But in the subgroup in DAPA CKD, they have about 270 patients of the IgA nephropathy, 254 biopsy-confirmed IgA nephropathy. With the SGLT2 inhibitor, the primary composite outcome is significant, like 0.29, with the hazard ratio of 0.12 to 0.73. And the AMBER trial, you also have a significant amount of people with the IgA nephropathy. I think 250 patients, something like this, in AMBER trial, and then is improve the primary composite outcome. So like you can use the SGLT2 inhibitor as a supportive care in IgA nephropathy. Yes.
So importantly, so far, this is the only study that looked at hard endpoints of it, the
Exactly.
hard creatinine relevant endpoints.
Yeah.
Although it's a secondary.
It makes you wonder whether you give this one to everybody, whether any of those drugs are necessary or not.
That's the question. So optimal supportive care is still very important in management of the IgA nephropathy. You want the blood pressure to be less than 120/70, low salt diet, regular exercise, weight management, smoking cessation, and kidney protection. Therapy like SGLT2 inhibitor is used. After I study about all these things, and then I received a patient for 20-year-old female with the G2 P0 with a 20-week unplanned pregnancy. With the hypertension and AKI. Never diagnosed with hypertension before pregnancy. She had the systolic blood pressure of 160. She was taking Levitral 100 milligram BID. No history of CKD. She has a baseline creatinine around 0.3. But recently in March, when she did the OB visit, she did the blood test. She had the creatinine 1.6 and proteinuria of 24. Our proteinuria was 6.4 grams. So long story short, we did all these different panels to find out why she had this thing. And then finally, okay, we did the biopsy. So the biopsy showed she has a global mesangial hypercellular with the estimated tubular loss of approximately 35 to 40%. And immunofluorescence show IgA 3 plus, CD 3 plus, kappa 3 plus, lambda light chain 3 plus, no IgG and OC1. There's a lateral dense microscopic, immune deposit, mesangia and mesangia region, and then we found a patient had the IgA nephropathy with the M1 as well as Htun. This is her progression. So she has about 1.7, 1.79, 1.72 in April. When she came to the hospital, her creatinine rose to around 2. We discussed about a lot of different treatment options. She left home, she came back, creatinine was 2.3, 2.4. She progressed really fast. And the EGFR initially started around 40 plus, and then eventually declined to 29 and 30 right now. So we did the literature review, like in IgA patient, there's an increased risk of preeclampsia, increased chance of getting cesarean section in preterm birth, small for gestational age, and then but there's a few total intrauterine and neonatal death. But when I look at a lot of different meta-analysis, they said that there's no risk of a vascular event or doubling of plasma serum creatinine. I'm like, okay, but why do my patient? When I look at all these criteria, what are the studies that they do the meta-analysis, and all the patients have creatinine like 0.8 or 1. Right? All the patients are less than criteria are less than 1.1, 1.2. Most of the study that they did was like 0.8. And then the maximum proteinuria is like 1.2, which is way different from my patient. The patient had creatinine of 1.5 to 2 now. Now proteinuria are like 6.5 to 7 grams now. So what do we have to do next? I thinking about the medication that approves SGLT2 inhibitor is a no. Is R no. Tapeo, budesonide, a lot of no. Because the animal study, there's a miscarriage. Nobody dared to do the human study.
Plaquenil is good. It's fine for pregnancy.
So hydroxychloroquine, that's one option.
Steroids,
And corticosteroid. So if you have, but what's nice, do we have to do corticosteroid? The increased risk of preterm, low birth weight, potential birth defect, like cleft pelvic, and fetal adrenal insufficiency, preeclampsia, premature red child membrane, reduced fetal body movement and breathing movement, neonatal sepsis, gestational diabetes.
Did you get that? Her blood pressure was elevated in the beginning, so did
Yes.
you control her blood pressure
With
and then reassess the proteinuria?
with the blood labetalol 100 milligram BID, our blood pressure was increased around 130 to 140.
And you still have to go further. I mean, you'll need to control it further, but that's a good.
Yeah, when they look, the OB look at the patient, baby is super small. Like at the time, like, do we want to give corticosteroid? And the patient EGFR is declining more in 2 weeks of time, from 2 to 2.3. So she is about 21 weeks. Yeah, at the time when we pointed out, she about 21 weeks. And like, what should we do next? After I learned all the IgA, right? Like, what should I do next? I don't know. Rebiopsy.
No, can you go back to that?
EGFR 30 is with the pregnancy. In pregnancy, you can increase the EGFR about 50%.
Do we know that creatinine before pregnancy?
0.3.
No, when he was like.
How long ago?
2023.
How long ago? Since advanced chronicity, there is 30%.
We don't know because the very first step she did let us after 2023 is now. So she lost that baby. That's the outcome now. But we don't know what is our renal function is recover or not, or we don't know yet. We still not starting any treatment more. Going forward with Dr. Mark.
So did you start prednisone or no?
We did. Yeah.
Was that patient on?
But my conclusion is the optimal supportive care with the ACE inhibitor, SGLT2 inhibitor, blood pressure control. This stay a very cornerstone of the IgA management. If you have eGFR less than 20, supportive care as tolerated. eGFR more than 20 to 30, you can consider SGLT2 inhibitor ACE or ARB. If eGFR more than 30 with the proteinuria of more than 1 gram, you can do ACE or ARB plus or minus atrasentan plus SGLT2 inhibitor or sparsentan. Systemic corticosteroid or iptacopan, the twice. eGFR more than 35, BEF treatment plus PRBD. There's a lot of questions like about the management of rapidly progressing IgA nephropathy in pregnancy. We don't have any data. Thank you.
So that was a great overview. I think what's really interesting to me is that we are going to see more and more IgA in the coming years as you have drugs, the diagnosis is going to be made more. And so we're going to be faced with a lot more of these. What are we going to do? They have normal renal function, so that piddling amount of albuminuria and how best to preserve the long-term outcomes. So I think what's really exciting is that there's going to be a lot more research in this area and how best to manage all of them. But that was a really great overview.
I concur completely. Excellent overview and very captivating case. But unfortunately, no doubt come already. I have to say I have given steroids. I use steroids. I use methotrexate in pregnancy in pregnant patients. I think the long-term outcomes, when you look for everything has a side effect, right? And how frequent are those? I don't think the frequency of those. The long list looks very scary, but I don't think the frequency is high enough to truly be worried if they are warranted. In this case, I agree it was not exactly clear what was happening. But let's say someone has class 4 lupus nephritis with crescents, would you not give steroids 22 weeks? You would, like you wouldn't, you should. You could go to that patient, you could treat them, you should utilize steroids as a therapy.
This was a span of like a week before she lost it. We biopsied her, had a result. They were in discussion what to do, and then she lost the baby.
I think that's very adequately.
Yes, and she had a very small baby at 20 weeks already, only 250 grams.
That was.
And the baby needed to get to 500 grams.
I mean, that's totally unfair.
Even if we didn't. And her BUN was already climbing, so within the next month, she would probably be on dialysis to minimize the. And she actually had planned to terminate before she actually lost the baby 2 days before.
Florida, you're not.
Actually, up to 23 weeks. Yeah, we had a large meeting and there was a lot of. discussions on this.
Yeah, this was Texas, you've been dead.
This is a very complex case.
Yeah,
You don't know exactly what the right course would have been in her case. I'm fully with you.
Thank you,
That was
everyone.
great, thank you very much.
That